Hi, I'm Shaun Melarvie, and I made this video specifically for women who have had a breast biopsy. Breast cancer is the most common cancer among women worldwide, and over 300,000 women will have a first conversation with their surgeon about a non-benign breast biopsy result. If you're watching this video, it's likely that you are one of those 300,000, perhaps even one of my patients. Perhaps you've already had a breast biopsy and you've had your first conversation, but you just can't quite remember everything he or she said. Or maybe you're about to have that first appointment and you want to better prepare yourself. The result of a surgical biopsy, it's kind of like a puzzle. And it's not a particularly difficult puzzle, but it does have to be put together the right way. The problem is the emotional burden of that diagnosis at that moment of discovery during that first appointment. I couldn't imagine fully comprehending anything beyond that point, at least for a little while. And this was the concern or the trigger for me to make this video. You're in a position where you want to know what your diagnosis is and what to do next. And by the end of this presentation, you will know the significance of your diagnosis and what the next step should be. We're going to assemble the puzzle. So the purpose of this presentation is to afford you that opportunity to better prepare yourself for your own first conversation, or as a review for that information that you have perhaps already received. Now I'm going to briefly establish my credentials. You see, that's me. This is the home page for the American College of Surgeons, of which I'm a member of. That's what those initials mean after the MD, FACS, Faculty of the American College of Surgeons. This means that I am board certified in my specialty. If you like, you can navigate to the page at www.facs.org. Now I'm going to disappear for a few minutes, but I'll return at those key points and during those times when we're going to shift our focus. I've been in a rural surgical practice in Door County, Wisconsin these past 21 years. Our breast team includes Dr. Gwen Pavlitz, Dr. Curtis Shear, and myself. Now for the next 30 minutes or so, you'll be my patient, and I will be your doctor. Consider this a second opinion, if you will. But I will be covering things more broadly than you would receive during your own first appointment, which will be in regard to a specific result or diagnosis. Now there are three possible results for your biopsy. There's a benign result, there's a non-benign result, and then there's inconclusive, which doesn't happen very often and typically means that we need more tissue. Most of the time, your result will be benign. However, this does not relieve the associated stress and anxiety that accompanies a breast biopsy. This is why that time from an abnormal imaging result, like a mammogram, to your first appointment with a surgeon or a surgical biopsy should be measured in days, if not hours. Most benign conditions don't require any variation from the standard screening for early detection, and this includes an annual mammogram, which begins at age 40. And although a self-breast exam is encouraged monthly, a clinical breast exam is part of the standard screening measures, and this simply means a breast examination by a healthcare professional who would typically be your primary care provider, and this is done once a year. Fibrocystic disease is a benign condition, and up to 50% of women, premenopausal women, have this, and up to 90% of women at some point in their lives, which kind of begs the question, why is it called a disease? I think of it as more of a condition. It does not represent an increased risk for breast cancer, but it can make the physical exam somewhat more difficult because the breast tissue tends to be irregular and dense. However, you can still distinguish a dominant or a discrete mass, especially if it represents a change. There are some benign conditions, sclerosing adenosis, apocrine metaplasia, and a radial scar, that are benign but could precipitate a breast biopsy. Although some microcalcifications are an indication for a surgical biopsy, not all microcalcifications represent breast cancer. They can occur in small blood vessels or be related to a prior history of surgery, but they can be associated with both carcinoma in situ and invasive breast cancer And these kinds of calcifications have typical characteristics, and they're described as fine, or linear, or branching and pleomorphic. One benign result that does imply an elevated risk is atypical ductal hyperplasia, or ADH. Now, this is not the same as plain ductal hyperplasia, which is a common finding and does not imply a higher risk. But women with ADH, atypical ductal hyperplasia, they have a 4 to 5 times the risk of breast cancer and should have a clinical breast exam every 6 to 12 months and could consider a breast MRI. We're now going to talk about non-benign disease, and this includes both in situ breast cancer and invasive breast cancer. And don't worry about these terms. You will know exactly what each one means as we progress through the talk. There are over 60,000 cases of non-invasive breast cancer diagnosed per year. The two types are lobular carcinoma in situ and ductal carcinoma in situ. Non-invasive cancer is the earliest form of cancer. And all an in situ cancer means is that the cancer cells have not violated the basal cellular membrane, which is an important cellular layer. I always describe it as an envelope in the sense that the tumor cells are still contained. And this is illustrated in the diagram on the right, where in DCIS, the tumor cells remain inside the duct, inviolate of the basement membrane. And this is in contrast to the invasive cancer in which the tumor cells escape the envelope of the basement membrane. So let's review LCIS first, lobular carcinoma in situ. In this case, the surgical treatment has receded over the years because the large majority of women with LCIS do not develop invasive breast cancer. LCIS is not actually a cancer and does not require a formal excision if it's found incidentally. But if it is found on a needle core biopsy, there is still an associated risk, about 10 to 20%, of DCIS or an invasive cancer. And because of that, a formal excisional lumpectomy is required in those cases. A lumpectomy not to remove all of the LCIS, but to make sure that there is not an associated cancer. LCIS is actually a risk factor for breast cancer, and a personal history of LCIS does imply a lifelong risk of invasive cancer at about 0.5 to 0.75% per year. This adds up to a cumulative risk of just over 21% at 20 years. Now we'll shift to DCIS, ductal carcinoma in situ. And like LCIS, DCIS implies non-invasion of the basement membrane. Not all DCIS progresses to invasive cancer, though, and this is despite extensive research. We still cannot reliably define which of those that will. So, unlike LCIS, all DCIS does require treatment. Again, because we don't know which of those that will progress on to cancer. But with treatment, overall survival approaches 100% for the simple fact that it's not an invasive cancer. It's stage 0, and as such, is at no risk of spreading. Most of the time, DCIS is treated with breast-conserving surgery or lumpectomy and radiation. It's rare that a mastectomy is required. Sometimes the DCIS can be extensive because it spreads along the ducts. It can be multifocal, and in these rare cases, a mastectomy might be required in order to remove all of the disease, because a lumpectomy does require excision to a negative margin. The tumor cells spread along the ductal system, and so there is a significant chance, about 25%, of a positive margin on that initial excision. And if that's the case, then a re-excision to a negative margin is still required. The great majority of time, breast-conserving surgery does involve radiation postoperatively, even with DCIS. And studies have shown recurrence rates of 30% without radiation as opposed to 12% with. But even with a mastectomy, there is still a 1 to 3% chance of a chest wall recurrence because it's impossible to remove all of the breast tissue from underneath the skin. There's always a small amount of residual breast tissue post-mastectomy. There is a small subset of patients, older patients, lower grade tumors, 1 centimeter or more margins. In these instances, there might be some consideration given to foregoing radiation, but even in those instances, radiation still does decrease the risk of recurrence. So the decision to omit radiation does need to be carefully considered. So now we're going to switch from non-invasive breast cancer to invasive breast cancer. Now remember, invasive cancer implies the invasion of the tumor cells through the basement membrane of the duct or the lobule. This means that there is a risk of invasion of the blood vessels or the lymph vessels, which in turn implies a risk of spread to distant sites. There are over 230,000 cases of invasive breast cancer diagnosed per year. The most common of these is intraductal carcinoma, which comprises about 85 to 90% of invasive breast cancers. These are the types that arise from the ductal tissue that is responsible for carrying the lactation products. The second most common type is invasive lobular carcinoma, about 10 to 15%. And this arises in the lobular breast tissue that's responsible for the making of the lactation products. In lobular carcinoma, invasive, carries the same risk of distant metastasis as does ductal carcinoma, but it can be more insidious and difficult to detect by mammography and other clinical means. And there are histological subtypes of breast cancer, but the treatment principles are the same. Tubular and mucinous carcinomas are subtypes of invasive intraductal cancers that tend to be less aggressive. Metaplastic carcinoma is rare, although I did see one a couple of weeks ago. And it's different from lobular and intraductal cancers, and it's typically more aggressive. Now you might be wondering what this picture of flowers is doing on the slide. I couldn't help myself. I was searching for images of these subtypes, and this is what I found at breastcancermystory.org. It was just such a beautiful image that, relative to everything else that I was, looking at, I just was compelled to share it with you. This picture is a picture of inflammatory breast cancer, and it's managed differently. Inflammatory breast cancer is characterized by redness and swelling, and this happens because the small lymphatic vessels in the skin get clogged up by the tumor cells. It usually involves over half of the breast, and because of its extensive involvement, chemotherapy is given first. Inflammatory breast cancer is an obvious diagnosis. If you do not have these clinical findings, you do not have inflammatory breast cancer. All right, it's key point time. And there are 2 points at which staging for breast cancer is defined. The clinical staging comes first, and this will guide further diagnostic testing with the collection of tissue and then completing the pathological staging. A widely used staging system is the T&M system. This is based on the definitive pathology results from the biopsy and other clinical data. And it's determined by the tumor size from the biopsy result, the nodal status, and the presence or lack of metastatic disease. T&M, tumor size, nodes, and metastasis or not. The clinical stage is based on the preliminary information from the physical exam and the non-invasive diagnostic tests. Sometimes, rarely, a CT scan of the chest or the brain or a chest x-ray might demonstrate distant metastatic disease or advanced stage disease. And then other times on examination there might be an abnormal lymph node that's palpable, or an ultrasound of the axilla might demonstrate an abnormal lymph node. And if you have a clinically positive axilla or an abnormal lymph node, this usually would negate the need for what's called a sentinel biopsy that we'll talk about shortly. The pathological staging is determined by tissue, and it is cumulative in the sense that it begins usually with a needle biopsy, and then additional information is added with the subsequent sentinel node biopsy if that's indicated, or an axillary needle biopsy, and lastly the excision of the tumor itself. Ultimately, the final pathological staging is determined by the specimen, And this includes the excisional lumpectomy or the rare case of a mastectomy, and also the sentinel node biopsy. Tumor size is the first component of TNM staging. T1 tumors are up to 2 centimeters in size, which is about the size of a penny. A golf ball measures 4.3 centimeters in size, which would be a T2 tumor. A tennis ball measures 6.7 centimeters, and so this would be a T3 tumor. This gives you an idea of the sizes, and they're not necessarily small. And lastly, a T4 tumor is not size dependent, but instead implies invasion of the skin or the muscle. The lymph node status is the second component of TNM staging. In clinical staging, a node might be felt on exam or seen on imaging studies. And a known abnormal lymph node might be biopsied with a needle, a small needle or a larger needle in the office. But in invasive cancer with a clinically negative node, that would be the case that a sentinel node biopsy would be done. Nodal involvement can range from a microscopic implant in one node up to macroscopic implants in multiple nodal involvement. Axillary nodes are divided into what are called level 1, 2, and 3 nodes. A sentinel node is a node that is one of the first in line, hence the term sentinel or guard. If a sentinel node is negative, it is most likely that all the nodes that follow in the chain are likewise negative, and there's no need to remove them for further pathological study. A sentinel node is targeted by injecting blue dye and a radioactive tracer into the skin around the nipple. Then it will travel to that first node. Sometimes there's 1 or 2 or 3 nodes. The status of the lymph nodes does give important information to guide chemotherapy. N0 obviously implies the absence of a positive node, whereas increasing amounts of positive nodes results in higher grades of disease. For instance, if more than 3 nodes are involved, that's an N2, and radiation to the axilla might be recommended. Often, in node-negative disease, systemic chemotherapy isn't needed, but there are many factors to be weighed, such as the age of the patient, the hormone receptor status, and the tumor stage, and sometimes genetic testing. The presence or absence of metastatic disease is the third component of TNM staging. Metastatic disease represents the spread of cancer cells beyond that local tumor site through the blood or lymphatic vessels. However, local invasion of the skin or the muscle is also considered metastatic disease. So, let's summarize our progress briefly. Thus far, we've reviewed both benign and non-benign biopsy results insofar as the different types of cancer and the differences between invasive and non-invasive cancer, as well as the aspects of staging. So now we're going to address the treatment of breast cancer. And I know this is a lot of information, but I do have the advantage of graphics and images to illustrate the concepts and the points that I feel are important for you to understand. There are 2 primary areas of focus in the treatment of breast cancer, and they are the treatment of the local disease in the breast, which involves surgery and most likely radiation, and treatment of metastatic or the potential of metastatic disease, which involves chemotherapy and or endocrine therapy. First, we must talk about the local treatment, and by that I mean to say addressing the primary tumor itself with the objective of minimizing the risk of recurrent local disease. And this is accomplished by the combination of surgical resection of the disease and radiation therapy in most cases. As I've mentioned, local treatment addresses the primary tumor in the breast, and breast-conserving surgery is by far the most commonly done. It does involve performing a lumpectomy to negative margins. In previous years, surgical margins of 1 centimeter or more were commonly obtained, but recent recommendations are to resect the tumor to a negative inked margin, meaning that as long as the inked margin is negative, there's no need to go back to excise further tissue. And breast-conserving surgery does require radiation. Although there are a few patients with DCIS in whom an argument might be made for not doing radiation In invasive cancer, there is no similar argument. There are some select tumors that are smaller and deeper within the breast tissue that might be amenable to smaller, more concentrated doses of radiation delivered over a shorter period of time. But the most common type of radiation is what is called external beam radiation, and this will involve treatments 5 days a week over a 4 to 6 week course. A mastectomy is much less commonly done. Historically, a radical mastectomy was the indicated treatment for breast cancer. This was years and years ago, and this involved removal of skin and muscle, including the pectoralis muscles, and it was very disfiguring. The modified radical mastectomy, which is what is done in selected cases, when indicated, involves the removal of the nipple and areolar complex, and then some number of lymph nodes underneath the arm. There is no extra skin that's excised or muscle, and the patient does retain full functionality of the arm. Now, this picture could also represent a simple mastectomy, which is the very same thing except that no lymph nodes are removed. This might be done for extensive DCIS or those breast cancers that are not amenable to breast conserving surgery. There is no difference whatsoever in the long-term survival between breast conserving surgery and mastectomy. This is old information. The standard treatment of breast cancer with a mastectomy has been obsolete for many years. Having said that, there are indications for mastectomy as the definitive treatment for breast cancer, and these include a multifocal disease in which there are multiple sites of cancer throughout the breast, and in those cases where there are large tumors relative to the volume of the breast. Inflammatory breast cancer is an indication for a mastectomy, and sometimes prophylactic mastectomies are performed, which is the removal of a benign breast simply to decrease the risk of a future breast cancer. And this has been typically done in those women that have a very strong genetic history. The entire goal of breast conserving surgery, other than cure, is an aesthetic symmetrical outcome without negatively impacting survival. And if a breast is too small relative to the size of the tumor, or if there are multifocal tumors, there is no reason to perform a breast conserving procedure if the residual breast tissue is such that there is a significantly asymmetrical outcome. In that case, the patient is much better served by a mastectomy with reconstruction. And there are different types of reconstruction, mainly those involving the use of implants, and then those involving the use of autologous tissue, which simply means borrowing the patient's own tissue, skin, fat, and muscle, from another part of the body. Illustrated in the diagram on the right is what's called a tram flap reconstruction, and this involves the transfer of skin, fat, and muscle from the lower abdomen up to the chest wall. As I mentioned, the two focuses of treatment for breast cancer are the local treatment and the systemic treatment. So now we're going to shift our attention to the systemic treatment, which addresses the potential of microscopic or metastatic disease. Neoadjunctive therapy means before surgery, and adjunctive chemotherapy means after surgery. Inflammatory breast cancer, remember the inflamed swollen breast? This requires neoadjunctive therapy to decrease the tumor burden, and this is then followed by a modified radical mastectomy because breast conserving surgery is really not an option. And then also, in larger cancers, T2 to T3, that are not inflammatory, there still may be a role for neoadjunctive therapy to decrease the size of the tumor so that breast conserving surgery might ultimately be done as opposed to a mastectomy. And this would be done after the tumor has been reduced or shrunk in size. And what I mean when I reference the use of adjunctive chemotherapy for the potential of metastatic disease is the following. In the case of positive lymph node, we cannot know for certain that the lymph node or the lymph nodes stop the tumor cells of that invasive breast cancer that invaded the basement membrane and entered the lymphatic stream. Did any of the tumor cells escape the lymph node and spread to a distant site? Or did the tumor cells not travel any further and were they removed with the lymph node? This is why we biopsy the axillary lymph nodes. The current thought is that if the sentinel node is negative, then the nodes thereafter are negative, and there's no need to perform a completion axillary node dissection to confirm that. That is why the lymph node information as far as the staging of the disease is so important for planning your cure, and of equal importance is the receptor status of the tumor. Both the lymph node information and the hormone receptor status guide recommendations for chemotherapy. Now, in a previous slide, I mentioned some of the subtypes of invasive breast cancer like mucinous and tubular and metaplastic. And although this information is informative and useful, the hormone and receptor status is actually more helpful in regard to guiding treatment and providing prognostic information. And all breast cancers undergo such testing. ER, PR, and HER2 are 3 of the receptors assessed on every specimen. And in the future, there will be additional, more specific genetic classifications. There are 2 broad classes of anti-estrogens in regard to hormonal therapy. 2/3 of breast cancers are ER positive, and that's a good thing because ER positive tumors are stimulated to grow by estrogen, which means that we can either decrease the amount of estrogen or we can decrease the effect of estrogen and thereby inhibit the growth of the tumor or the risk of recurrence. And the first type of anti-estrogen, the one that has been around the longest, is an estrogen receptor blocker. It's called tamoxifen. And tamoxifen inhibits the growth of the tumor and decreases the risk of recurrence by binding and blocking the estrogen receptor. It blocks the effect of estrogen on the tumor cells. In contrast to tamoxifen, aromatase inhibitors lower the amount of estrogen in the body by stopping certain hormones from turning into estrogen. These inhibitors are not effective in premenopausal women because the drug will not stop the ovaries from producing estrogen. So tamoxifen is the drug of choice in premenopausal women who have functioning ovaries. And because aromatase inhibitors are overcome by functioning ovaries, they are only used in postmenopausal women. All women with ER-positive tumors should receive endocrine therapy. This means taking medication that counters the effect of estrogen on the ER-positive tumors. ER-negative tumors would more likely be treated with chemotherapy, as are HER2-positive tumors. And HER2 is a 3rd receptor that's routinely tested for. It stands for human epidermal growth factor receptor. It's an oncogene. An amplification or overexpression of this plays a role in the development and progression of certain types of breast cancer. It occurs in about 15 to 30% of breast cancers. But the HER2 receptor can be targeted by monoclonal antibodies that will attach to the HER2 receptor on the surface of the tumor cell, and it will block the cell from receiving growth signals. There are some cases where a genetic test might be helpful in addition to the hormone receptor status to define those patients that are at a risk of recurrence. These are in early stage no-negative disease patients. The type of test is called a genomic assay, and it uses a sample of the cancer tissue itself to analyze the activity of a group of 21 genes. And the result of this test, as I mentioned, can predict the risk of breast cancer from coming back later. The Oncotype DX is the most commonly used. Not every breast cancer patient needs genomic testing. It is reserved for early stage breast cancers that have not traveled to the lymph nodes. But it can also be done for node-positive disease in postmenopausal women. And this is indicated by the graphic or the table. I have now covered all of that information that I will typically address in my first conversation that I have with my patients following a non-benign breast biopsy result. It's not a short conversation nor an easy one. It is overwhelming because of all of the information, and it is difficult to absorb against the backdrop of the emotional stress of the diagnosis that is learned at that very moment. The last thing my patient or any patient is really able to do after learning that they have breast cancer is to assemble a puzzle. A puzzle comprised of a picture that they most likely don't even understand. It is not fair. And this is why I wanted to make this presentation for you And this is why it is helpful to have a friend or a loved one with you for that first conversation. And many breast centers, including our own, do have special nurses called navigators that can be there with you in the room at any step along the way. It is my fervent hope that I've made some sense of the puzzle before you and that I have, in some small measure, addressed your concerns. I hope that this has been a useful resource for you and that you have the appropriate support around you. The important thing to remember is that all will be well. The sole focus is that of a cure, no matter what. Your doctors and your nurses and all the other providers are there for you to help you and to guide you along your way. There will be difficult days, to be sure, but in the end, we have a singular purpose: to fight cancer in all its forms and to win.